Hi there. My name is Dr. Michael Vallis. I'm a health psychologist, and I'd like to make a presentation to you around managing diabetes distress, really embracing the mental health aspects of living with diabetes within scope of practice, both for diabetes providers as well as mental health providers. And I really like to kind of emphasize the second part of my title, from overwhelmed to empowered, the journey of change. These are my disclosures, and I'll begin by defining type 1 diabetes as a pancreatic insulin insufficiency. The beta cells of the pancreas get killed off, as you well know, and therefore external insulin is required for glucose regulation. Quite a dramatic change in a person's life. And there's a lot that's understood about diabetes, and it clearly is a pure biomedical disease. The pathophysiology is well understood, the treatments are highly developed. But the irony of diabetes is at this very same moment that it's a biomedical disease, it's also a behavioral challenge. Because, of course, the work of diabetes management is not done inside the clinic by the clinician, as would be the surgical procedures inside the OR, but it's actually done by the choices that the patient makes and their family in the context of ongoing issues in their life. And that's really, I think, an important perspective. Now, a reference point in understanding this presentation is that psychological issues, mental health issues associated with diabetes are not experienced by all. Very few people experience psychological issues with diabetes all the time, but many people experience occasional, time-limited problems. And maximizing diabetes outcomes really requires overcoming these challenges. In essence, if you're living with diabetes or affected by someone with type 1 diabetes, it actually makes you different. And at some level, you need to embrace this. And that's why the outcomes that are important to appreciate need to be understood from a patient perspective. And I would just suggest from a mental health perspective, it would be quite valuable for us all to think about the journey of successful type 1 diabetes management and diabetes support is first disease acceptance, treatment acceptance, and readiness for self-management based on treatment recommendations. If you've ever used the word denial with a patient or a family, it's probably not psychological denial, it's probably issues around disease acceptance. Similarly, if you've ever been frustrated by not really seeing adherence rates to medical therapies as you would expect or hope, that's a treatment acceptance issue. And of course, change is hard, and an individual has to be ready to change. So it's important to understand mental health as a continuum. And one of the things that's really useful, and I actually quite enjoy doing this, is asking people, what's it like to live with diabetes? What words do people living with diabetes use to describe their experience of diabetes in their life? And I'm just showing you an example of something from a recent workshop. And if you just quickly scan this word cloud activity, you'll see there's not one positive word there. Not one positive word. And so what does that tell us just from a very high level with regard to mental health issues in diabetes? Nobody wants to be sick. And so there needs to be some support to addressing the psychological aspects of living with type 1 diabetes in order to help individuals and family overcome these barriers. Disease acceptance is easy to understand if you take the perspective of the health beliefs model. So what are the attitudes that people have regarding their condition? And there are three questions, as you see on this slide, that I think could be useful. What words do you use, as we've just gone through? That'll give you an idea of whether is there any light in that picture, or is it all dark? How serious do you view diabetes to be in your life? Could be high or could be low. And how much personal responsibility do you have? These are useful questions. And because they're simple and they can be asked at really multiple points. So think about the life of someone living with type 1 diabetes at any transition point, because these can be questions that can be brought in at that point. And you can see a very rough, and please don't take this sort of breakdown slide as gospel, but it gives you just kind of a rough idea that, someone who presents with high seriousness and high personal responsibility is likely going to be accepting and move forward. But somebody who sees it low serious, it's no big deal, and low responsibility, or they have high seriousness and low responsibility, then they may need some support. And so the purpose of of this type of an assessment isn't to kind of give you the end of the story, but the beginning of the story. Where's the patient and what can we do to support them? Treatment acceptance also can respond really well to very simple questions that tap into also a health beliefs perspective called perceived needs and concerns. To what extent do you think you need this medication? To what extent do you have concerns? And really nice breakdown here. High perceived need, low perceived concern, accepting. High perceived need, high concern, ambivalent. Low perceived need, low concern, indifferent. High perceived concern, low perceived need, skeptical. And this becomes really useful. And just to sort of show, there's a lot of research that's used this model in diabetes that can be really, really helpful. And so I just wanted to kind of give a very quick sort of summary of what could be easily adapted tools that sort of open up these conversations for individuals. Let's now take a step back, because I really want to begin with sort of emotional experiences, because this is often something that many medical health providers struggle with. How do they manage the emotions? And many of the mental health issues are really identified through excess emotions or emotions that are really a person would struggle with. But this is a really important slide, in my opinion, because this is normal psychology. Normal psychology. The perception of threat leads to the feeling of anxiety. The perception of loss leads to the feeling of sadness. And the perception of unfairness or intrusion leads to the feeling of anger. So when you see anger, sadness, anxiety in an individual with type 1 diabetes or their family members, you don't immediately assume there's something wrong here. We might want to think, well, what is the perceived threat, the perceived loss, the perceived intrusion? Does it match the situation? And the reason that this is important is because these emotional experiences that you see here are actually the way that humans operate. And so then we have the opportunity, but what do we do with these? And what we understand about emotions is that we some of the emotional experiences that people have are actually what are called primary emotions. They're actually normal. So if you've had a threat, then you should be anxious. And if it's a little threat, a little anxious. If it's a lot of a threat, a lot of anxious. And so this is actually very understandable. And if you're working in diabetes and you think about what would you be experiencing if you were going through what the patient is going through, that might help you to determine whether, in fact, this emotion needs to be just sat with, just expression and support is the way you cope with primary emotions. Think about a grief experience in, let's say, someone in your friendship circle. How would you support someone going through grief? You wouldn't tell them what to do. You wouldn't tell them to buck up and get over it. You wouldn't be engaging them in sort of action. You'd be just supporting them and allowing them to express themselves. And it's only the secondary emotions where they get excessive and out of proportion that we start thinking about referrals or cognitive therapies or other types of professional interventions. I'd also like to sort of normalize the issues around mental health and diabetes, because you can see sort of this is kind of life, right? On the one hand, on the right there, you've got your plan for the day, you're organized, you've got a strategy, a structure, and then of course life is challenging. But what's important about this is the following. As stress goes up in a person's life, their plan gets interfered with. So this kind of active coping goes down. So stress can be overwhelming. And this one can actually be important. Now, most of the comments that I've made so far are really designed to support us in normalizing the experience of someone with type 1 diabetes or the family members. I want to emphasize that because the current language, when we talk about mental health in medicine, is really to use the language of psychopathology. So we keep using words, well, maybe he's depressed, or maybe he's got an anxiety disorder or a personality disorder, and that may well be true. But it doesn't necessarily have to be true. And so if the only language we have is the language of psychopathology, then that can become a little bit challenging, because there could be some labeling that happens. In other words, pathology of the psyche. There's something wrong with you. Well, if you're living with type 1 diabetes and you fear nocturnal hypoglycemia, is there something wrong with you? Or is nocturnal hypoglycemia a scary event? And if it's a scary event and you're scared, you don't have pathology, you have type 1 diabetes. So it's important that we sort of look at it in context. And so I like to think about this kind of continuum of distress. And at some point in that continuum, the person may well benefit from a diagnosis. But there are many, many points in the journey when one would want to normalize the experience. And there's another model as an alternative to the psychopathology model that many can find helpful. And that's what we call the quality of life model. And so the quality of life model is quite simple. If I wanted to assess your quality of life, I would really want to know two things about you. I want to get a sense of the extent to which, let's say in the last 2 months, how distressed have you been? How much distress have you experienced? But importantly, I'd also want to know how much well-being have you experienced? Because life is a series of things that pull us down and prop us up. And then we can start to understand that. And understanding distress and well-being is quite important. What I really like about the distress dimension is we can understand what I call the drivers of distress. So what's driving that distress? Is it the disease? Is it the diabetes? And you could ask your patient, if you didn't have diabetes, would you be experiencing this? Now think of hypoglycemia. If you didn't have diabetes, you wouldn't have hypoglycemia. So of course you wouldn't. So any of the mental health issues that we would experience around things like hypoglycemia are disease specific. Of course they are. What about, social anxiety or social distress around, wearing a pump? Or people sort of in your face about diabetes. Again, that's specific to diabetes. That kind of mental health issue is really belongs inside the clinic. It's a diabetes issue. Then there are problems of living, and social services need to be really engaged for many of our patients to support this. And of course, then we also have psychopathology. So this quality of life model includes psychopathology. So you lose nothing by adopting this model, but you gain much in terms of understanding the experience. And not only with regard to the distress element, but also with regard to positivism and resiliency. And I think I want to start there. So it's really important for us to touch base on this idea that, when you're living with a chronic condition that's burdensome and in fact life-threatening, you could be in DKA by the end of the day. You could be unconscious in the mall because you've had a hypoglycemic event, during any particular day. It's also useful to think about how to embrace this positivism. Take a strength-based approach to promoting resilience. And there's research suggests that in the happiness field, that it's not a big effort to actually infuse happiness into a person's life. And you can develop habits, devoting time to family and friends, practicing gratitude and optimism, savoring life pleasures, engaging in meaningful activity, being in the present. These are things that people can do. And evidence suggests that noticing the good in life, in fact, is to a significant degree sort of intentional activity. That, we've got genetics and, there are people that walk around like, Linus and Sad Sack and are kind of down, but you can do a lot to intentionally increase happiness. And so optimism really as a habit. And here you see little Charlie Brown, someday we'll all die, Snoopy. And Snoopy's response, well, true, but on all the other days, we will not. And so there are actually established interventions, as you see, setting aside time for gratitude, positive thinking about oneself, practicing altruism. The random acts of kindness are very therapeutic, affirming one's most important values and savoring positive experiences. So it's important as we understand really the lived experience of type 1 diabetes, really that we can also empower people directly. How can you help? Where can you help with the lived experience of type 1 diabetes? And I think, it's important to understand the stages of the disease, of course. Certainly the diagnosis, which is really a crisis. And, when this happens in children, it's really important to understand both the child and the parent. The distress that's associated is actually really important. It's important to maintain a perspective on the family and not allow the disease to overwhelm. And also, we've talked about the sort of physiological honeymoon of type 1 diabetes, but there's also a psychological honeymoon. The first couple of years, a lot of attention really focused in on diabetes, but then it fades away. And don't be surprised if that drifts. And that's actually normal, to be expected, to be supported. Taking control. If we look at living with type 1 diabetes through the sort of lens of the family, there are times when it's up to the individual to really take over the control of the condition. And so, you might say, let's say a child gets diagnosed at age 10. At what point does the child really take control? And there is no definitive right time. It really varies from family to family. And you have to really look at sources of motivation. Whose idea is it? Understand the emotional distress, and really understand that, especially in teens, the team leader idea. And remember, when you're negotiating the control issue, it doesn't have to be all or nothing. It really can be a dimensional thing. And so you can try for a bit. If it doesn't work, you can step back. It's important in type 1 diabetes to really understand, the nature of being a teen and the challenges of with teens. And important to really normalize these, because we tend to use in our society sort of negative language around teens, their problems, they're difficult, etc., etc. Well, they're not. They're humans that are developing, and they're going through a very important stage of development that needs to be understood and supported. And so, determining responsibility, of course, is an issue, certainly knowing when to back off. And again, I would really encourage you to take a collaborative, problem-solving, temporary trial and error approach to really manage that. Because it's really a big deal to really understand adolescence and the transition issues. The tasks of adolescent in some ways are inconsistent with the principles of diabetes management. I really think it's important to acknowledge that. Because there are two main psychological tasks of adolescence. The first is to individuate or to establish autonomy, which involves defying rules and regulations and identifying with the opposite of the parent's belief. So you think about it in this way. Child's walking down a hallway, and they're at a stage of life when they need to know that they're in charge of their life. And you say to the child, turn left when you get to the end of the hallway. Now, if the child turns left, that's not necessarily confirming their autonomy. But if they turn right, you want them to go left, they turn right. That's obviously them. That's autonomy. That's why they do it, in order to ensure that they are in charge. And then the second one is to be as close to your peers as possible, right? So I want to be my own person. I want to dress my own way, just like all my friends. There's a real inconsistency that we need to be okay with. And it's also important to understand the human brain, that teens and young adults are actually unable to take a long-term view. What you're seeing here really is the development of the frontal lobes. And the frontal lobes are not fully developed in boys until the ages of 27 to 29, and girls between the ages of 23 and 25. And so, the brain is really, really important. This is critically important because of the term psychological reactance, which is the normal tendency for a person to resist if they feel that control is being taken away from them. Tell me what to do, and if that's not my idea as well, I'll resist you. Think of COVID and the vaccine and all the protests. That's exactly what's happening. People are reacting because they feel they're having their rights taken away from them. And so the reactance is kind of a normal situation. And so we have to really understand this, because then our job is to sort of keep diabetes out of the normal development of adolescence. It's important to understand that we have this new concept called emerging adulthood. So we used to, in maybe 20, 30, 40 years ago, people would be quite capable at 18, but still dependent on their families. But by the time they became 21, they were fully launched, fully independent. Now that sort of launching phase goes from 18 to 30. It's called emerging adulthood. Two real stages to it. Early on is really trying to get independence, try to get education. And then the second half of that is to really establish sort of a life course and relationships. So it is actually important to appreciate that. And what do we know about emerging adults, right? They struggle to establish functional relationships with diabetes providers in healthcare settings and adult settings. Unless they're ready to adhere to recommendations, it really requires a very good patient-provider relationship. Transition is challenging, and there's lots of evidence, and that once transitions are made, there are still challenges. So individuals really do require a lot of support. And that then sort of allows us to think about the adult with type 1 diabetes. And here we have the clinic transition, which can be really challenging, and it'd be interesting to see whether we can benefit from technologies and remote learning, etc., to maybe navigate a little bit easier the transition. Getting on with life is actually challenging, because when you sort of get to the early stage of adulthood, life gets really busy. Life gets really focused. You start to develop a lot of both professional and personal responsibilities. Imagine children and mortgages and careers becomes really, really difficult. And also, children sometimes are better able to maintain social relationships. And so in some ways, it's easier for a child with type 1 diabetes to receive support from their friends because they basically say, what are you doing? And the person with diabetes tells them, and then they're cool with it. But in adulthood, people tend to have all kinds of ideas that and end up often sort of telling people with type 1 diabetes how they should manage their disease, which is pretty frustrating. If you live with type 1 diabetes, then you're kind of an absolute expert in diabetes management, and someone who doesn't even know about the disease is telling you what to do. And then, of course, the next sort of step as we navigate all of the disease acceptance and treatment acceptance and readiness are the complications. And the complications can be really difficult. The burden associated with that can be really, really important to appreciate. And, the other thing that's important is the kind of a crisis revisit. I often hear people describe, well, you've been through this before, so you know how to do it. And from a psychological point of view, when you have to go through really crisis-like events, it doesn't get easier. You don't get better at it. As a matter of fact, in some ways, it gets harder because you know how difficult it is. And many people who have repeated crises they sort of remember fondly the naivety they had at the beginning of the last crisis because they know just how bad it can be. So again, these are the domains in which professional support can be incredibly beneficial. And you don't have to be a psychiatrist, psychologist, mental health professional to actually provide this kind of a support. So now let's dig a little into some of the diabetes-specific mental health needs that I would suggest belong inside diabetes services. And if we look at our Canadian clinical practice guidelines, we've had mental health chapter for a number of iterations of the guideline. And each iteration of the guideline, we are more and more engaging diabetes providers in identifying and managing the mental health issues. And so this is the concept of diabetes distress, which is the distress associated with living with the disease. And you can really, I love the question, if you didn't have diabetes, would you be experiencing this? I find that patients can really direct me to what may be diabetes distress, what might be problems of living distress, or what might be psychopathology-based distress. And just asking, well, what's the big deal? What's so difficult about living with diabetes? And, the behavioral demands can be overwhelming, right? I mean, it's like a 24/7 job, and it's incredibly complex. There's so many things that, impact. It's constant. It's really, really hard to take a break. And I just kind of show you, right, this sort of from the Diatribe organization, 42 factors that affect blood glucose. I mean, how can any one person be on top of all of these issues that are going to be managing their glucose levels? And the social challenges of diabetes can be really difficult. And I know the stigma and the bias is important to acknowledge. I also think that we need to take the concept of stigma and expand it to include feeling judged, and not just as a person, but as not doing enough work. So have you ever seen someone in a diabetes clinic who feels like they're a student being called into the principal's office? Or someone who might want to, I forgot my logbook, I didn't bring my meter so you can't download it. Have you ever thought, well, maybe they don't want you to see? And if you ever felt that, you might think, well, why wouldn't they want you to see it? And the answer is probably because they feel you're judging them. So that may begin as my patient is compliant. They didn't bring in their meter for downloading. Maybe the problem isn't the patient. Maybe the problem is that the patient doesn't feel safe telling the clinician what's really going on. And that's a judgment issue. So I think this issue of discrimination and stigma isn't just talked about in the extreme. I think there's a continuum here that we can all be mindful of. And, it's also important to understand, particularly with type 1 diabetes, just how well people do, just how powerful people become living with type 1 diabetes. They develop, agency, they develop a lot of coping skills, they actually develop really sort of good, mature skills. And I sometimes think that, people with type 1 diabetes as a class are actually less neurotic and better friends than people without diabetes, because they know life is hard and they deal with it, and they know that support is helpful and they're providing support. And so it's actually quite interesting. And again, that's where we want to balance distress with well-being. Quickly, just to show the burdens associated with diabetes, this is from the Diabetes Attitudes and Wishes and Needs study. And, we had 17 countries and, you can see, over 1,000 people living with type 1 diabetes. And when we looked at, the impact on life functioning, 83% of people are saying it has an impact. It has a negative impact on my life. And this is where the diabetes distress instrument has been developed and can be really, really helpful. It's a scale that can be completed. As a matter of fact, you can access online a version of this so that you could direct patients to a website where they could complete the scale on their own. And the diabetes distress scale has a number of dimensions attached to it. It could be sort of useful as a screening instrument because you might be able to detect, okay, here are people that are distressed, but this is where the main drivers of their distress are. The management tasks, hypoglycemia, eating, just being overwhelmed by feeling powerlessness, physician-related distress, the clinical relationship, family relationship, social perceptions. And this could be really useful as you navigate with your patients. And as you navigate with your patients, I just want to emphasize the importance of the relationship. And one of the ways that you can use the relationship that I think could be beneficial is to think about your relationship having three components. First is the bond alliance. This is what we've all been trained to establish as a foundation. It's the professionalism, that professional caring and supportive connection, which is really, really essential and has to be maintained. But it's not sufficient to promote empowerment and change. You need to, using that bond, also establish a goal alliance. Are you and the patient actually oriented in the same direction? Now, just think for a moment about a young female with type 1 diabetes who omits insulin as a part of an eating disorder. Just think about the mismatch of the goal alliance. You do not have a goal alliance with that person because that person wants to maintain their weight and they're willing to skip insulin in order to do it. So that's their goal, to keep their weight under control. Your goal is the opposite of that. Their goal is no insulin. Your goal is more insulin. It's so important to understand that because we can't tell people to take insulin. We can, but they won't. We need to help them make it their goal. And that's really where the important patient-provider relationship comes in. So if you have a bond alliance, do you have a goal alliance? And with a goal alliance, then you can talk about the task alliance. What are the tasks necessary to achieve the goal? And so this evidence is actually pretty strong around psychotherapy. What are the characteristics of success in psychotherapy, regardless of whether you're doing psychodynamic psychotherapy, cognitive therapy, acceptance and commitment therapy, you name it. And it seems to be if you have a bond and a goal and a task, those are the key associated with change. And so I just want you to reflect on that in your work. Also, it's really important to embrace motivational communication strategies because motivational communication has really been demonstrated to really meet people where they are. But notice the comment on the right. We communicate to negotiate. So communication just isn't to understand because we want to encourage our patients to adhere to a particular strategy of management. And so motivational communication can be super helpful when people struggle. And you can see on the screen, ask, listen, summarize. That's the essence of communication. We ask the patient what their experiences are, and we listen really carefully. And that can be hard sometimes because people can make comments that you disagree with, but it's their belief. So you can't tell them they're wrong. You can, but you'll break the bond and you won't be able to help them. So ask requires us to listen, park all our stuff and really listen. And then the only way the patient knows they've been heard is if you summarize it back. So ask, listen, summarize, then invite. And the invitation is the negotiation piece. And that's when your recommendations, that's when the opportunities for education come in after the summary. And the summary is, I think, in a way, almost foolproof. Because if you're right, you're right. And if you're wrong, you'll become right. So if you summarize to a patient and say, well, if I think what I hear you telling me is this, if you're right, the patient will say, exactly, yes, you got it. Now you've got common ground. You can enter with an invitation to negotiate a new direction. But if you're wrong, what I hear you saying is this, and the patient says, well, not really. You then say, well, oh, thank you. What is it that you experience? So the patient will make you right. So it's actually really, really effective. And the basic relationship dynamic here that we're trying to incorporate is we start by acknowledging, normalizing, empathizing with the patient, regardless of their behavior. So think of that young woman who's not taking insulin. That person may make you extremely uncomfortable. We acknowledge, we empathize, we normalize. Then we ask permission to work together. We ask the person what their thoughts are, and then we ask permission to provide our ideas. So as a framework, that's a dynamic in a relationship that's been associated with really understanding and self-management support. And what we do is we use this in the context of the spirit of motivational communication. These are the attitudes that we need to really embrace, which is to be non-judgmental and curious, to avoid these yes, but kind of arguments, and to just be aware that people are pulled in multiple directions, what we call ambivalence. So managing diabetes distress can be really effectively achieved using communication strategies. I also want to touch on the fear of hypoglycemia, because this one is actually important. And that's because hypoglycemia experiences can be more traumatic experiences than stress experiences. See, the human brain kind of can handle stress. Life is hard, life is stressful, and we can take stress into stride and we manage it. But traumas, we can't deal with. Traumas are too big. They overwhelm the brain. Hypoglycemic events, especially serious hypoglycemic event, low to the point where conscious ability to treat it is compromised, becomes really too much. And one of the indications that we know it's too much is how many people actually treat a low adequately, or they just eat until they feel better. And most people will eat until they feel better. Why? Survival. They're just trying to reduce the distress. And so reducing the fear of hypoglycemia is really about managing the fear before you manage the hypo. So you could ask your patient, what is your safe zone? What blood sugar range do you feel comfortable with when you leave for the day? And then you don't make recommendations based on ideal. You do make recommendations based about how you can make the psychologically safe zone closer to the medically safe zone. And you do this by what we call shaping. Just negotiate with the patient. Let's say they say to you, I'm comfortable between 12 and 15. Over 15 is too high. Under 15, I'm worried if I leave the house that I'll go low. Okay, and then you sort of work to try to shape that down. And we published a paper on this a few years ago, really trying to encourage people to sort of take this fear-based approach. So just try to remember, if you can, fear of hypoglycemia is a fear management problem before it's a hypoglycemic management problem. And so I hope you found this presentation of some use, and thank you for the opportunity to make this presentation. Thanks.